and good evening, everyone. Welcome to the 106th Blue Hills Virtual Seminar. Blue Hills Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And today's platform is brought to you by Blue Hills Ethiopia in collaboration with We Care. So Blue Hills Ethiopia is a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge and preventive medicine. And I'm your host, Dr. Iheno Tadele, a general physician and first aid trainer from Blue Hills Ethiopia. Today, it's a pleasure to have Dr. Feven Moges here with us to have a seminar on wound care for nurses. So Dr. Feven Moges is a stoma and wound care specialist, and she also has previously presented on Blue Hills virtual seminars on the topic surgical site infections. So if any of you participants have missed the previous seminar by Dr. Feven, you can access it on our YouTube channel. Okay, so Dr. Feven, the stage is all yours. We can begin.
Good evening, everyone. I'm so happy to be here. Thank you, Blue Health, and also We Care for having me here. So today we're going to talk about advanced wound care, principles of advanced wound care, by the topic, when the wound speaks, it heals. So the contents will be, next slide, please. The contents of this presentation will be stages of wound healing and their pathologies, assessment of wound, goal of management for the type of wound tissue, choice of cleansing solutions, choice of dressing materials, wound care practice in Ethiopia, and what advanced wound care says about our current practice and where our wound care needs to advance to. Next slide. So the stages of wound healing, all wounds follow the same process of wound healing, which starts with hemostasis within a few seconds after the injury, and then comes inflammation, recruitment of macrophages and other mediators, and then comes proliferation, and then comes maturation. So this process can go on naturally from hemostasis to inflammation to proliferation and finally to maturation, or this process can be halted by different phenomena and can get stuck at one process. Next slide, please. So we said when the wound speaks, it heals. We need to learn the language of wounds. So each wound speaks in its own way. There is no general management for wounds. Like, we don't manage 10 wounds in the same way, because each wound speaks in different way, and one wound even speaks in different way at different stages of the healing. So what we do at the beginning of wound care might be different from what we do in the middle of wound care, and also what we do at the end of wound care. So as a nurse, we need to learn what the wound is speaking. That's where the wisdom of wound care happens. So how do we learn the language? There is this triangle of wound assessment. Triangle of wound assessment, as you see incorporates peri-wound skin, evaluation of the peri-wound skin, the wound age or the margin, and the wound base. So to evaluate the wound base, we use the TIMES acronym. The TIMES acronym, T comes for tissue type, I is for infection status, M for moisture balance, E for exudate, and S for size or dimension. So we evaluate the peri-wound skin, we evaluate the wound age, and we also evaluate the wound base. So it's not only the wound base that we evaluate. We also need to evaluate the others, like the peri-wound skin and the wound age. Next slide. So what do we evaluate on the peri-wound skin? The periwound skin, we need to see signs of inflammation. Around the wound, there can be redness, there can be pain. So we need to see if there are signs of inflammation. The other thing we need to see is maceration. It's very important that we evaluate maceration. If we see maceration, it's usually because there is high exudate which comes out of the wound, and which is making the peri-wound skin moist. So we need to see if it has maceration. Also rashes. Are there rashes? And also signs of effects of plaster. So the plaster we have on market is not a good type. It has zinc in it, and also it's not of good type. So it usually creates maceration or even ulceration. So we need to be very watchful of the peri-wound skin, because wound heals from the ages. If the peri-wound skin is destroyed, then that means there are no cells to migrate to the wound base. So when we remove the plaster, we need to be very gentle. So in my practice, I usually see nurses and doctors removing a plaster with just one of their hands. And, they just remove it aggressively. So usually the skin peels off along with the plaster because they are not gentle enough. So what I advise is we use one of our hands to remove the plaster and the other hand to support the skin, and do it gently. Do it very gently, especially at areas where there are hair follicles. Please do it very gently, because one, we inflict pain on the patient, the other, we hurt the peri-wound skin. So we have seen the peri-wound skin, and then we also evaluate the types of tissues. When we come to evaluation of the types of tissues or wound bed, there are different types of tissues. The first one is a granulating type. So if you see red tissue, that means the tissue is granulating. The second one is epithelializing. Epithelializing tissue is pink. So if you see pink wound base, it's epithelializing. The third one is sloughy. Sloughy wound base is usually yellow. So if you see a yellow wound bed, it's sloughy. And the fourth one is infected, usually greenish and whitish, and that's an infected wound base. The fifth one, it's necrotized or a scar. So that's also the one kind of tissue. Next slide, please. So the other thing we need to evaluate on the assessment from the triangle of wound assessment is types of ages. The first one is sloping ages. So that's the most natural healing type of ages. So if you see sloping ages, that means the wound is on its way to heal. The second one, punched out age. Usually these are arterial wounds. The punched out age, it usually shows peripheral arterial wounds. And the third one, undermining ages. Undermining ages means underneath the age there is space, or underneath the ages there is an undermining area. So we need to evaluate this because we need to clean the undermining part. And the fourth one, rolling ages. This is the granulating tissue is covered by skin. This is a very difficult kind of wound to heal because the granulating tissue is covered by skin. The granulating tissue cannot grow to each other. So we need to also evaluate that. Next slide, please. The other thing we need to evaluate it's the exudates. So there are different kinds of exudates: serous, hemoserous, sanguineous, purulent. So the serous type is usually normal. If it's increased than the normal, it may suggest infection. So serous is usually clear or pale. Hemoserous is pink kind of exudate. This one is thin, watery, but pinkish, and it usually occurs when the wound is deep. And the next one is sanguinous. Sanguinous is usually red, so it usually happens due to trauma to blood vessels. If you see the purulent, it usually shows a pyogenic infection. Next slide. So why do we evaluate tissue types? Evaluating tissue types, exudates, and everything gives us a perspective on how to treat a wound. So for tissues, for granulating and epithelializing tissues, our management goal is to promote healing, prevent and treat infection, prevent or treat infection, moisture balance and pain management. We prepare for grafting, and we protect surrounding skin. So this granulating and epithelializing tissues, they are on their verge or they are on their way of healing. So we need to promote a healthy way of healing. Next slide. Sloughy, infected, and necrotized tissue, this needs to be debrided because in the presence of dead tissue, wound doesn't heal. So our management goal for sloughy, infected, and necrotized tissue is to debride devascularized tissue, achieve homeostasis, treat or prevent infection, moisture balance, promote wound healing, and protect surrounding skin. But we need to be careful to differentiate between peripheral arterial disease wounds and other wounds, because for a PAD wound, we don't debride. We don't debride at all. We need to refer the patient to a vascular surgeon, general surgeon, orthopedic surgeon, to any of these specialties. So we need to differentiate whether this is a PAD wound or other wound. If it is a PAD wound, we don't debride at all. But if it is under other wounds, our goal for sloughy, infected, and necrotized tissue majorly is to debride the devascularized tissue. Next slide. So we have evaluated our wound. We have evaluated what kind of tissue it is. We have seen the periwound skin. We have seen the ages, the exudate. We have also measured the size. We have decided whether it is an infected or non-infected wound. These are all needed before we jump into management. So when we come into management, cleansing solutions and dressing materials, our evaluation dictates what we do next. So choice of cleansing solution, antibiotics, dressing material, and subsequent plan depends on wound assessment. So the cleansing solutions, we have different kinds of solutions, but in Ethiopia, we are limited to a few kinds of solutions, normal saline, hydrogen peroxide, vinegar, acetic acid, povidone iodine. So these are the solutions we use, but normal saline is the only safe solution we can use. The rest are totally unsafe. So in my practice, there are only two things that I use to cleanse a solution, either normal saline or distilled water. Otherwise, I don't use anything at all. You can see hydrogen peroxide. It has a germicidal effect against anaerobes. We usually use it here if it has pus. If wound has pus, we usually clean it with hydrogen peroxide. But it's very harmful for newly formed epithelium. It's cytotoxic, and it can cause bleeding by dissolving clots. So hydrogen peroxide, our neighboring country, Kenya, they have stopped using it 20 years ago. In the wound care, in advanced wound care, nobody uses hydrogen peroxide. We are the only ones still using it. In Africa, I have only seen the practice in Kenya, and in Kenya we don't use they don't use hydrogen peroxide. Vinegar, so we use vinegar, or what we call aceto, 1/3 of vinegar and 2/3 of anise. We dilute that and we use that. It is effective against Pseudomonas, but it's toxic to fibroblasts and it's not isotonic. So vinegar is not also advised. The next one is povidone iodine. We use it left and right in the country, and this is also toxic. Povidone iodine above 4% is toxic to a wound. The povidone iodine we find on market, which is 10%, is very toxic to a wound. So it's advised not to use it. So usually people ask me, so you said don't use hydrogen peroxide or povidone iodine or vinegar. So what shall we use for infected wound? I mean, I don't say don't use hydrogen peroxide because we don't have dressing materials which have antibiotic in them. So for now, let's continue doing whatever we're doing until we have, as a country, dressing materials which are impregnated with antibiotics. If we have those dressing materials, there is no need to use these aggressive cleansing solutions. But know that these are not good materials for wound. And this needs to change for all of us. And coming to sodium hypochlorite, it's disinfection of, it's used for disinfection of inanimate objects. It's highly toxic to fibroblasts. So we don't use this also. The rest, you see, you don't find them here in market, but they are available in developed countries. PHMB, octenidyne, superoxide solutions. These are very good solutions for infected wounds, but we don't find them here. Next slide, please. So this is what I mentioned priorly, hydrogen peroxide. It's currently out of the wound care practice in advanced, from the advanced wound care. So probably we are the ones using hydrogen peroxide. Next slide, please. So here also I have tried to elaborate about acetic acid, vinegar, or what we call aceto. It's toxic to bacteria, and the wound comes very clean to your eyes. This is where the delusion is, by the way. It becomes so clean to your eyes, so you think you're helping the wound heal, but the wound is clean to the eyes, but it doesn't heal. So it delays healing, but it makes it clean to the eyes. Next slide, please. So we have seen cleansing solutions, which cleansing solutions are safe, which are unsafe. After cleaning the wounds, there comes dressing materials. So when we come to dressing material, we use gauzes, right? Wet or dry, we use gauzes. So is gauze a dressing material? Yes, no. Next slide, please. Gauze is not a dressing material. Gauze is only a cleansing material. So we use gauze in advanced wound care just to clean wound bed, and we throw it away. We don't dress wounds with gauze in advanced wound care. So ideal dressing material needs to contain infection prevention or treatment. It has to modulate moisture balance. It needs to promote granulation or epithelialization. It needs to provide autolytic debridement. Mind you, a dressing material can do debridement, not necessarily surgically. Debridement can happen with just a dressing material. And it manages pain, and it's moldable for cavity wounds. Gauze doesn't fit to any of these criteria. It doesn't have infection prevention or treatment benefit. It doesn't balance moisture. It doesn't promote granulation or epithelialization. It doesn't give autolytic debridement. It doesn't manage pain, or it's not moldable for cavity wounds. So gauze is not a dressing material. Next slide, please. So we have thousands of dressing materials in advanced wound care. Like, you cannot even name them. Like, if you go to Germany, there are different types of wound care materials. If you go to India, there are different kinds of wound care materials. To the US, to Canada. So each country has different manufacturers which are produced to supply those ideal qualities we have mentioned above. But in general, we have a portfolio to manage infected wounds and non-infected wounds. So a portfolio to manage infected wounds, if skin is at risk of breaking, I mean, if the wound is, granulating or epithelializing, we can use a hydrocolloid. If we want autolytic or enzymatic debridement for a necrotic tissue, we have hydrogel catalytic gel. If we need exudate management, for example, there are wounds which are highly exuding. We have different kinds of wounds that absorb the exudate. So they take away the exudate. We use alginate with silver. Ag stands for silver. So silver has a quality to fight infection. So we use alginate silver and hydrofiber silver. We also have foam, like foams like foams which have silver on them. They absorb the exudate, and they also have silver and PHMB, which are bactericidal. So they give away this silver and PHMB to the wound bed to fight off the infection, and they also take away the exudate. And if wound is at final stage, we use tool dressing. Tool dressing is what we call Vaseline dressing here. So it protects the epithelializing or the final stage of the wound until it's totally covered by skin. Next slide, please. Portfolio to manage non-infected wounds, prevention and protection. We use hydrocolloids and autolytic or enzymatic debridement, hydrogels or catalytic gels. Here what you see, it's more or less the same, but you don't see silver here. For non-infected wounds, we don't use silver-based dressings. So they are more or less similar, but here we don't have silver-based dressings. So I don't expect you to be familiar with this kinds of dressings, because if you don't see them, it's very ideal to remember them all. But my point here is for you to remember there are different dressings for different kinds of wounds and for different kinds of uses. And gauze is not a dressing material. There are thousands of dressing materials which we can use for different kinds of wounds. For example, if you come across a wound which is highly exuding, there is an option. You don't use gauze, you can use foam. And for example, if you have a wound that has a cavity, there is an option. You don't use gauze, you use alginate. And if you have a wound that's already healing, you have a tool dressing, or what we call Vaseline dressing. So the point here of mentioning different kinds of dressing materials for you is not for you to remember them all, but for you to realize there are different kinds of dressing materials. Next slide, please. Okay, so here I brought some wounds which we have treated here with just dressing materials. So you can see on the left side a wound which is it's a surgical site infection. and you see it's inflamed. So let's evaluate this wound. You can see the periwound skin, right? It has signs of inflammation. The periwound skin is red, inflamed, and yeah, it seems the inflammation is ongoing. So if we don't do something here, there will be ongoing inflammation. So you can also see there is the wound plate. You can see kind of granulating and sloughy tissue. You can see necrotized tissue. And there seems to be an undermining area. So this wound definitely requires debridement. So we have debrided the wound. It's around the shoulder area. He's a diabetic patient. So, it has risk of non-healing. So we did extensive debridement on the right side. Next slide, please. So at the beginning, you can see on the left side, it's a big wound. And after treatment, it took around 2.5 months, and it has completely closed. So we didn't do graft here. We didn't do flap here. Here, what we did was just antibiotic-based dressing. We used powder, we used silver-based dressing, and also foam because it has exudate. Next slide, please. This one is also treated with antibiotic-based dressing. On the left side, you can see immediate post-op, but on the right side, you can see the wound kept on gaping and gaping and gaping because it was closed with pressure. The skin has necrotized and it kept on gaping. So you can see underneath intestinal tissue is coming upward. So for this patient, she was on steroid for a long time, so we couldn't do graft or flap. So we used antibiotic-based dressing, silver-based dressing. Next slide, please. Yeah, so on the beginning, you can see on the left side, it was a huge wound, which was gaping and the intestine was coming up. On the right side, it has healed. So we just used antibiotic-based dressing to manage this wound. Next slide, please. So on the left side, you can see an amputated below knee amputation of a diabetic patient. So you can see a necrotized tissue, and there is also periwound skin. It shows inflammation. So if we don't do extensive debridement here, it will the inflammation will keep on going, and it can cause necrosis at a large level. So we did extensive debridement. On the right side, you can see we did an extensive debridement. So the thing was, the patient was to be about to be reamputated. So she was amputated for three times. So the fourth time she was to be reamputated again, but we did extensive debridement. The right side, you can see the extensive debridement. Next slide, please. And yeah, so at the beginning, it was like the left side, and you can see the right side, it has completely healed. So even, our amputation rate in Ethiopia there is only one study I've seen done in Wallagga, it's around 30%. So 30 patients out of 100 who develop 30 diabetic patients out of 100 diabetic patients who develop wound get amputated. Our neighboring country, Kenya, has a 6% amputation rate. So you can see what wound care will do. And for this patient, she was about to have above knee amputation, but her leg was salvaged just because of the appropriate wound care. Next slide, please. So you can see how we treated the cleansing solutions, the dressing materials, and the difference we make was just dressing with the right materials. If we use the wrong materials, it won't heal, but with the right materials, it has healed. So I just wanted to take a closer look at wound care practice in Ethiopia using the materials honey, silver sulfadiazine, and maple. So these are the most frequently used wound care materials. Next slide, please. So the use of honey, it's internationally a controversial issue. So I've been to seminars, symposiums related to wound. Using honey is an issue. Like some people support using honey, some people don't support using honey. But using hydrogen peroxide is never an issue. You don't even hear it being mentioned. Like nobody mentions whether we need to use hydrogen peroxide or not, but whether we need to use honey or not is mentioned. So it's internationally a controversial issue, but different researchers have shown honey is a good resource to treat wounds, especially in resource-limited countries like ours. There are also guidelines advocating against honey use. But you know, when we say let's use honey, and even when it is a topic, it's not like we bring the honey from the beehive. No, it needs to be medicated. So it has to be medical grade honey, not a honey that directly comes from the beehive. So what does medical grade honey do? With strict, they medicate it with strict criteria to ensure the efficacy and quality of honey. It needs to be free of pollutants such as herbicides, pesticides, heavy metals, and antibiotics, gamma irradiated to ensure it is free from harmful endospores. It meets strict production and storage standards. So when we say let's use honey, we don't use it directly from the beehive. So let's be mindful of that. Next slide, please. The other thing we use left and right is silver sulfadiazine. Silver agents are toxic to bacterial cells and the skin itself and can delay healing, especially when it comes to silver sulfadiazine. It's able to retard keratinocytes and fibroblasts. So here comes, I've been, if you saw the previous slides, I've been advocating for silver containing dressing. So I was saying like, I used silver based dressing for this wound and it healed, but still silver based dressings, internationally, they are controversial issues. Some of them support them, some of them say, no, let's not use silver based dressing, but SSD cream or silver sulfadiazine ointment or cream is more toxic to wounds than silver based dressing. So silver containing dressing showed significantly better healing than the control on one study, and silver sulfadiazine showed significantly worse healing time compared to non-silver group. So in general, we don't advocate for use of silver sulfadiazine ointment or cream. Next slide, please. So this is the practical thing I can show you. This wound on the left side, it was being treated with silver sulfadiazine ointment for 2 months. So I have started treating it on the right side. 2 days later, you can see the difference. You can see how it looks on the line of healing. On the left side, you can see it doesn't come close to the line of healing, but the right side, you can see it's a granulating tissue, slabs are removed. So if you compare silver sulfadiazine ointment to silver-based dressing, the silver-based dressing is better. Next slide, please. So you can see with just the silver-based dressing, it has closed off on the right side and it has completely healed. So it took around 10 weeks to close off completely. But before I started treating it, it was treated with silver sulfadiazine for 8 weeks and it only got worse. It wasn't healing. Next slide, please. So the other thing is the use of Mabo. Sorry for the spelling error. I said Mabo. So Mabo is moisture exposure, burn ointment. So its major use is for burn wounds. So it is an oil-based herbal paste. It's reported to be effective in managing burn wounds and more commonly used in Asia and Middle East. Mabo contains beeswax, sesame oil, and some other herbal materials. It has an anti-inflammatory and moisturizing effect. Majority of trials comparing wound healing between Mabo and silver sulfadiazine favored Mabo. So in general, Mabo is better than silver sulfadiazine. But on the treatment, on further treatment of wound, area needs further study. Next slide, please. So this is what we're practicing. Maybe on the question section or the comment section, you can write for us which ones which materials you're using outside of this I mentioned. It might help us for our next discussion. So majorly I have seen we used honey, we used Mabo and silver sulfadiazine in our practices. So the future of wound care in Ethiopia. Worldwide, nurses are the ones who specialize on wound care. So even me, when I went for class, majority of the class were nurses. Almost all of the class were nurses. I have seen internationally a few wound doctors, but majority are wound nurses. So in Ethiopia, we need trained wound care specialists. Wound care is so huge. So even if you like specialize on wound care, there are subspecialties, burn subspecialties, vascular ulcer subspecialties, debridement subspecialty. So wound care is huge, and we need specialty and subspecialty collaboration among the wound specialty and subspecialties, and also in collaboration with plastic surgeons, general surgeons, orthopedic surgeons, pediatric surgeons. So we need to work closely with all these people. So in Ethiopia, for the last 2 years, when I practiced, I've seen different cases. I haven't worked alone in a single case. There always needs to be someone involved in the care. So we need to think on that line that we need specialty in Ethiopia, and also we need to work closely with specialists and subspecialists. And also the interesting thing is, like in Nairobi, when plastic surgeons round in when plastic surgeons round in wards, there always is a wound care specialist with them. So they get to see the wounds, but who decides how to treat the wound is the wound care specialist. It's not the plastic surgeons or the general surgeons. It's the wound care specialists who have specialized on which materials to use. So we need wound care specialists. So in our future needs to hold specialists. And the next one is Maggot debridement therapy. And we also need to have vacuum assisted closure. Next slide, please. So this is Maggot debridement therapy. As you see, this black fly, the larva of black fly, is very helpful in the debridement of so many kinds of wounds. So it's a biotherapy involving the intentional introduction of live disinfected maggots or larvae into an healing skin. And so what we do is, in a laboratory, we make this sterilized maggots. We sterilize the maggots. We don't make the maggots, but we sterilize the maggots, and those maggots are taken and put on wound. So after 72 hours, we open the wound, and the maggots clean the dead tissue. They don't eat the living tissue, they just eat away the dead tissue, and they remove all the dead tissue. So that way, we save a lot of time and money. The patient doesn't have to go to the OR again and again because it's debrided by the maggot. So be aware that it needs to be the green kind of fly, not any kind of fly, but the green kind of fly. So we don't have that in our country, but in the future, it's good to bring that into the picture. Next slide, please. So the mechanism of action of maggot debridement therapy, it has a debridement effect, and also it stimulates healing. It has biofilm inhibition and eradication. So these are the mechanisms of action. Okay, so these are the references, dressing materials. You can see the references. So finally, this is what we say: when the wound speaks, it heals. The wound needs to speak first before it heals, and we need to learn the language of the wound. Otherwise, we won't know how to treat it.
No, okay. Thank you very much, Dr. Feven. It was a very interesting presentation. So we can move on to the question and answer section of today's seminar. So participants, if you have any questions regarding today's topic, please feel free to write down your questions in the chat box.
I see one question. What is the reason to stop using hydrogen peroxide for wound care? Because it's toxic to fibroblasts and to the tissue. It means it makes the wound clean, but it also makes it the wound not to heal. The other question is, what was the name of the fly? It's the green kind of fly, but I also need to refer the specific scientific name of the fly. But it's the common, like the kind of fly we see, but it's specifically the green kind of fly. And it also needs to go into the laboratory to be sterilized. We just don't bring the maggots and put it on the wound. It needs to be taken to the laboratory to be sterilized. What PAD means, it's peripheral arterial diseases. So peripheral arterial disease is a disease that comes when arteries are blocked by thrombus or anything that clots, that blocks the way. So if wound happens on top of peripheral arterial disease, it's very difficult to heal it because oxygen and nutrients are not delivered to the wound. So it's a very challenging kind of wound for which we usually do amputation. In what materials we can dress the wound? For now, all we can use is gauze, because that's what we have in the country. But in the near future, there will be different materials to use the wound. So as I mentioned, I don't expect everyone to know those dressing materials by heart, because if you don't practice it, it's not easy to know it by heart. But know that gauze is not a dressing material. For now, that would be enough. Does bleach recommend for wound care? No. Bleach is very toxic to the wound. So they say what you don't drink or what you don't put in your mouth, don't put on wound. Like you don't drink bleach, so also don't put it on wound. Bleach is very toxic for wound. What type of honey for wound? Yes, as I mentioned, medical grade honey, not the honey that we bring from the beehive. That's not also available. So I know, like, we're speaking of things that are not available on the market, but be aware that honey from the beehive is not the standard. It needs to be medical grade honey. Yeah, PAD and other types of wound management, that will be another topic. It's a broad topic. Can we use honey for diabetic wound? Yeah, it has helped in a way, but the recent guideline recommends against honey for diabetic wounds. Totally. Why not gauze is not dressing material? Because I have mentioned the ideal dressing material benefits like moisture balance, treatment or prevention of infection, management of pain, being moldable to a cavity. All this gauze doesn't provide. So gauze is not an ideal dressing material. But what we have here is gauze. For now, we use gauze. And is our wound management right in our country? Okay. So if you ask me from my point of view, no. But I know that so many wounds have healed. I know that you have contributed a lot to heal wounds, and wounds have healed. So what I say is it's not totally wrong. It has worked in a way up to now, but it needs to change. There is a better kind of wound care. All right. How do we differentiate PAD wound from others? That's a broad topic, a discussion for another time. Some person wash the wound by salt water. What about your advice to them? Yeah, salty water is like normal saline, but you know you need to make it isotonic, which means not too much salt, because not too much salt can also damage the wound. Which plaster is recommended? There is a kind of what they call Hypafix, which I usually use for my patients. That plaster, they usually use it for patients on dialysis. It has micropores. Like the plaster we use, if you have seen it, it's flat, it doesn't have micropores. But the advised plaster has micropores in it, which means the skin can breathe. That the one we're using, the skin cannot breathe. Yeah, interesting. The mechanism of honey in wound healing process. It has moisturizing effects. It gives moisture for the wound, and it also has debriding effect. It has autolytic debridement. So it takes away the dead tissue, and it also have it has hydrogen peroxide in it. Honey has a natural hydrogen peroxide in it. It's not as powerful as the hydrogen peroxide we use, so it has oxidizing effect, which kills bacteria. So that's the mechanism of action. Okay, why not use DNS? DNS, it has dextrose in it, and we don't need to put sugar on wound. Of course, there are practices that use sugar on wound, but it's not advised. Dextrose can facilitate bacterial growth. I think those are the questions in general.
Oh, yeah. Yeah. Thank you very much, Dr. Feven.
Very welcome. Thank you for having me.
Yeah, so on behalf of Blue Health Ethiopia and We Care and all our participants, we would love to thank you for taking the time to present on today's Blue Health virtual seminar, and it was quite interesting and insightful as well. So we hope we will be seeing more of you on our Blue Health virtual seminar in the future with other topics, related topics as well. So if you have any last remarks that you want to add, let me give you the stage one more time.
I just want to appreciate our nurses for taking care of very difficult wounds. So I see very difficult wounds in my practices, and the major ones who take care of these wounds are our nurses. And I truly want to appreciate them for assisting patients. And I also see wound care has a high burnout. it's a very difficult job. So kudos, thank you for taking care of our patients, and thank you for joining this virtual seminar to learn more about wounds. There is a lot more to learn. And I thank Blue Health and WeCare, and thank you all for facilitating this. Have a good night.
Okay, thank you and good night, Doc.